Thank you, Fozia, and good evening, everyone. I would like to give I would like to give thanks to Oncology Club for giving me this opportunity. ConCerv, a prospective trial of conservative surgery for low-risk early-stage cervical cancer, was first published in International Journal Gynecological Cancer in 2021. The first author is Kathleen M. Skimler. 85% of cervical cancer cases and death occur in low and middle income countries. The current standard treatment for early stage cervical cancer is radical hysterectomy for women who do not desire for fertility and radical trachelectomy for women who desire for fertility preservation. But radical surgery is associated with significant morbidity and requires specialized training in gynecologic oncology surgery. Several retrospective studies have shown favorable results with conservative surgery. To further evaluate the oncologic outcome of conservative surgery, the ConCerv trial was performed. The primary objective of the study was to evaluate the feasibility of performing an oncologic outcome of conservative surgery. It was a prospective single-arm multicenter study which included 14 institutes in 9 countries from all over the world. 100 evaluable patients were enrolled between 2010 to 2019. Eligibility criteria included the patient with FIGO 2009 stage 1A2 and 1B1 with squamous cell or adenocarcinoma variety, tumor size less than 2 cm, no LBSI, negative imaging for metastatic disease, depth of invasion less than 10 mm, and conization margin and cervical curetage negative for malignancy and high-grade dysplasia. All patients underwent a cervical conization and endocervical curettage. Women desiring fertility preservation underwent a second surgery with pelvic lymph node assessment. Women not desiring fertility preservation underwent a second surgery with simple hysterectomy and pelvic lymph node assessment. Women underwent an inadvertent along with a 90% credible interval. Posterior probability was 3% or more. The two-year incidence of recurrence was estimated along with 95% confidence. Survival was estimated is the method of Kaplan and Mir. Patient demography was 33 pelvic lymph nodes participant, 40-47 and surgery in this patient is feasible with regard to immediate failure. The median follow-up for all participants was 36.3 months. In ConCerv trial, 3 patients developed recurrent disease with a 2-year cumulative recurrence rate is 3.5%. In case of conization, recurrence rate was 2.4%. And in case of simple hysterectomy, it was 0%. But in case of inadvertent simple hysterectomy, recurrence rate was high, that was 12.5%. Significant adverse event rate was 2% and pregnancy rate was 27.5%. Study by Shah no association between cervical radicality and cervical after adjustment of the lymph node dissection. Study according to is known when in child it remains unclear and require further study. It is the first comprehensive prospective evaluation of conservative surgery. All surgical specimens were centrally reviewed. But the study was limited for a prolonged study period of almost 9 years, and lymph node assessment and laparoscopic approach were not consistent across site. And there is no current standard of care for patients who underwent inadvertent simple hysterectomy. Two ongoing prospective studies are SHAPE trial and GOG 278. If this study shows similar result, the standard of care may change from radical hysterectomy to conservative surgery. So in conclusion, the ConCerv trial suggested that the conservative surgery is safe and feasible for low risk early stage cervical cancer. That's all, and thank you all for patient sharing.
And histology-specific nomogram accurately and survival. Cox proportional hazard regression models were created, including known clinical risk factor. A prognostic histology-specific nomogram for 3-year recurrence was developed using the result of Cox proportional hazard model for each histologic subtype. Results. 820 patients identified with stage 1 cervical cancer, 715 patients had a diagnosis of squamous cell carcinoma, 105 patients had adenocarcinoma. 19% patients experienced a disease recurrence. Among them, 20% squamous cell carcinoma, 17% adenocarcinoma. Tumor characteristics differed by histologic subtype. Squamous cell tumor had LVSI more compared to adenocarcinoma, and squamous cell carcinoma tumors were larger and more likely to be high-grade. But distribution of depth of invasion was similar between squamous cell carcinoma and adenocarcinoma. Upon evaluating the impact of various risk factors on recurrence-free survival by histologic subtype, varying factors were noted to impact recurrence. For squamous cell carcinoma, LVSI depth of invasion tumor size where all was independently associated, which shows tumor size in adenocarcinoma of CSR displays statistically significant role in recurrence-free survival of 36 months, but not in squamous cell variety. And this survival curve shows depth of invasion for squamous cell carcinoma is placed statistically significant role in recurrence-free survival of 36 months, but in patient of adenocarcinoma, it does not significantly changes recurrence-free survival. In histology-specific nomogram, there was an interaction effect identified between LVSI and tumor size for both squamous cell carcinoma and adenocarcinoma. Clear differences are observed in recurrence risks. For instance, a hypothetical patient with squamous cell carcinoma, tumoral LVSI, superficial invasion, and tumor size more than 5 cm would have a recurrence rate of 18%. But a patient with adenocarcinoma and the same intermediate risk factor, relapse risk is 45%. There are several scenarios that would not meet Sedlis criteria for post-hysterectomy radiation, but have a chance of about 20 to 40% of recurrence by the current histology-specific nomogram. This picture shows adenocarcinoma nomogram, and it shows a hypothetical patient with adenocarcinoma with the characteristics of LVSI and superficial invasion 2 cm tumor would not meet Sedlis criteria for adjuvant treatment. But based on histology-specific nomogram, 32% chance of recurrence. And this picture for squamous cell carcinoma nomogram for recurrence. And here is also the same calculation. Here it shows squamous cell carcinoma, negative for LVSI, deep invasion tumor size 4 cm would not meet Sedlis criteria. But calculating the nomogram, it shows recurrence is 25%. Limitations of the study. It would have been unethical to follow patients prospectively without adjuvant treatment in a more contemporary analysis given the current state of evidence. While it is important to recognize that these patients were managed many years ago with outdated staging models, treatment models, and radiation techniques, current treatment standards utilizing the Sedlis criteria are still based on the same data. Other study limitations include restricted sample size, particularly of cervical adenocarcinoma patient, and the retrospective nature of the study. Additionally, due to minimum demographic information collected, this study were not able to fully evaluate the impact of race or other factors on recurrence risk. And the strengths of the study, it is the first analysis to examine risk factor for recurrence specific to each histologic subtype. Excluded those patients with high risk disease and only evaluated patients who received no adjuvant or neoadjuvant treatment. Expert pathologists reviewed all specimens, and the data was collected in the control setting of randomized clinical trials. Conclusion. The Sedlis criteria. a one-size-fits-all risk-based algorithm for post-hysterectomy radiation is designed to trigger a recommendation for adjuvant radiation. This approach may no longer be relevant for every cervical cancer subtype. Histology-specific nomograms accurately and linearly represent risk of recurrence for both squamous cell carcinoma and adenocarcinoma tumors, and it may provide a more contemporary and tailored tool for clinicians to base adjuvant. Thank you all for patient sharing.
And I would like to request Dr.
Studies that have been selected. They are not randomized trials, but they provide very good information to deal with these studies one by one. So I think the first study, which is ConCerv study. So I think the most beautiful thing about that study is that when you see the trachelectomy population and their outcomes. So I read through the paper that at least 13 of the women could actually go and have childbearing potential, and they did have fertility. So that is one major success, not only of this study, but also of our recent staging system, where in early stage now we divide 1B1 and 1B2 with the ability to do trachelectomy and to offer patients more conservative surgery. And I know that in low middle income countries, this is not very important. The reason being here, median age of diagnosis of cervix cancer is way beyond the age of pregnancy. So even though the trial looks very good from fertility sparing surgery, we don't see as much of patient population coming to us in that age. Having said that, if there are such patients, it is an option that can be offered to the patients. And I also saw some very fancy statistics that have been adopted study. Bayesian statistics adopted to see if that there were hardly 4 recurrences, which translated to around 4% or 5% recurrence rate. So clearly, this is an approach which should be studied in larger cohorts. We appreciate a vast majority of these patients also had minimally invasive surgery because they are coming from the same group and in 10 centers when LACC trial was still going on. So it does indirectly also suggest that in a select subgroup of patients, minimally invasive surgery may not be that unsafe when tumor size is small, who had undergone simple hysterectomy. And I think that is the most important lesson for us, because we see a lot of patients operated in the community with simple hysterectomy and then coming to us for adjuvant treatment. And it happened to us a lot in PARSER trial also, because we don't do elective lymphadenectomy for these patients. We end up offering them chemoradiation to these patients, presuming that their lymph nodes are positive. So what I learned the most out of this study is that if patient has undergone irreverent surgery or hysterectomy and has an incidental diagnosis of cervix cancer, then having a discussion to do lymphadenectomy is also very meaningful, which we don't employ normally in our clinical practice. Having said that, if lymph nodes turn out to be positive, patient still has to undergo chemoradiation. But overall, I think for early cervix cancer, there are quite some lessons. These are non-conclusive. This has to be taken forward into a further study, but it does bring in a hope for doing more conservative procedures. And also coming from radiation oncology perspective, because most of the tumors were less than 2 centimeter, I think there is a need for radiation dose de-escalation, because if lymph node dissection can be done more selectively in this group and parametrium can be left undissected, there is also a role for radiation dose de-escalation if you have to employ for some patients with early cervix cancer, either because of medical comorbidity or other things. So I think there are a lot of thought processes which come. Nothing is conclusive, but has to be tested. Coming to the second study, Beyond Sedlis, and I think that we'll now go on discussing for years Beyond Sedlis because it's opened our eyes to a lot of things. And one most important thing is that traditionally from head to toe, you offer adjuvant radiation when chances of relapse increase 12 to 15%, prophylactic neck irradiation, any kind of irradiation, rectal cancer irradiation for 8%. And I think as a community, we have done a lot of disservice to our patients for years and years because Sedlis criteria is selected to allocate radiation if risk of local relapse is 30%. And I can understand that this happened because there is always a risk of adverse effects that you can cause with radiation. So there is always a balance between advocating radiation versus not. And I understand that when radiation was evolving, there was also this trial POTEC-1, which demonstrated detriment in endometrial cancer. So people were very careful in offering adjuvant radiation. But I think with these two publications, Beyond Sedlis, where very carefully you can select patients based on individual risk factors, and also with changing therapeutic ratio of adjuvant radiation with IMRT, I think we have to now balance risk benefit ratio. And for any patient, I would suggest that if we have still not changed our practice in Tata because we still have to discuss this paper within our group, but I would suggest that whenever risk exceeds 15%, a discussion has to be made with the patient and they should be referred for adjuvant radiation, preferably IMRT, because even 10 to 15% risk is too much. Alternatively, the discussion could be with the patient is of a more careful observation and data in the hospital know that there is a good salvage rate. So the discussion, because if two factors are there, then only go ahead with radiation. Now using nomograms, a much more intelligent this, I would like to end the comment on this, and others can maybe possibly comment. We don't hear you, Dr. Shahana, you're on mute.
Yeah. I think that is enough. You're taken much comment on the both papers and the analyze the papers. So I think no need to comment on more because it is in our country, it is 11:10 and I think here it is 10:40. So you have office tomorrow and all are exhausted till date. So we now to conclude this session and